Hi, in this episode of Psychiatry in 5 Minutes, we're going to be talking about the affective disorders, that is, depression and mania. To begin, major depression is defined by depression with physical signs, what you know as SIG-ECAP signs, that is, sleep, interest, guilt, energy level, concentration, changes in appetite, psychomotor retardation or agitation, and thoughts of suicide. If you have physical signs, that's major depression. So the question often clinically is, when should I give a medication to somebody who's depressed? The answer is when they have physical signs. That is, when they have 4 or 5 physical signs, it's good to give a medication. Know that the antidepressant medication beats placebo only in moderate to severe. It doesn't beat placebo in mild depression. Major depression, though, is a disease that is recurrent. Often there's a reason why somebody gets depressed to begin, but after that it begins to take on a life of its own. And in 3 years, half of everybody with a major depression will have another episode. The medications for depression all work about the same. The SSRI medications, such as fluoxetine, sertraline, citalopram, S-citalopram, vortioxetine, they all work about equally well. They have problems with sexual dysfunction, and up to 40% tremor, anxiety, and stomach upset can be a problem. The other test question sometimes is citalopram has QT interval problems and is both age and dose related. So in other words, 60 and above don't go above 20 milligrams. S-citalopram is just the S isomer of citalopram, does not have QT interval problems as far as we know. Fluoxetine has a very long half-life, and it gums up the cytochrome P450 system, causing blood levels to rise of lots of other medications. Paroxetine has problems in that it has no active metabolite and kind of ends with a bang, and people can have withdrawal symptoms. Also in pregnancy, it's known to cause pulmonary hypertension at times. Other medications, have their trouble too. They all are equally effective. Bupropion is helpful for smoking cessation, has a very low risk of sexual dysfunction. However, it can increase your seizure risk, and there was one study showing high rates of seizures in people with bulimia. Venlafaxine, helpful in chronic pain, helpful antidepressant, but increases blood pressure 5 to 10%. Desvenlafaxine is simply the major active metabolite of venlafaxine. Trazodone is sedating, and because of that, it limits its use as an antidepressant, but we often use it as a sleeping medication. Its bugaboo is that priapism, or prolonged and painful erections, can be a problem. Mirtazapine is helpful. Sedation is sometimes helpful, and it can cause weight gain, though, in about 20% of people. Duloxetine is helpful in chronic pain. It can cause rare liver failure. Medications which are used less often are the tricyclic antidepressants, drugs like amitriptyline, nortriptyline, imipramine, desipramine. These are often used for chronic pain, especially headache pain. The problem is, though, that sedation and its anticholinergic effects can be a problem with it, and they can be quite dangerous in overdose. A 2-week therapeutic supply can be fatal. The good thing about the tricyclics, though, is there's a clear blood level on which they work. If you are in that blood level and they are not working, you can easily move on. And you can get the blood level readily, although you often have to send it out to outside labs. Mao inhibitors, or monoamine oxidase inhibitors, are rarely used but are helpful drugs and helpful for anxiety. To be on those, however, you have to be on a tyramine-free diet. Tyramine's an amino acid. Otherwise, your blood pressure can shoot up. More common problems with MAO inhibitors is orthostatic hypotension, but the biggest problem is they have dangerous drug interactions. So what you try to do in major depression is, of course, have the symptoms remit, have someone be totally better. About a third of the people are totally better with the first pill you try. About a third, they're half better. A third, not much happens. So what do? If somebody's totally better, you're a brilliant doctor, continue that. If somebody's half better, you take that half, because you don't know what's going to happen, and you add on. you can add on another antidepressant, an antipsychotic, or lithium, or thyroid extract, and that can be helpful in pushing somebody kind of over the finish line. If you're in the third where nothing happened, get rid of the pill. It didn't work. Try another medication. Remember that there's other non-medication treatments for depression. The treatment that works best always is ECT, or electroconvulsive therapy. Seizures are what is the treatment. Electricity is used to cause the seizure. Seizure resetting the brain is, we think, what helps. It is the most effective treatment in psychiatry, getting about 70 to 80% of the people all the way back to their old selves. Memory trouble can be a side effect. It usually fades over time. Ketamine, or S-ketamine, it can be helpful very quickly. Ketamine is given twice a week IV, S-ketamine through nasal insufflation, and that can be helpful when other pills fail. TMS, or transcranial magnetic stimulation, is helpful for almost half the people, and here you're using magnets to stimulate the brain. Exercise is helpful. Light therapy, that is using bright lights, is helpful in seasonal affective disorder, but also helpful in non-seasonal affective disorder. The light therapy has to be at least 10,000 lux. Now, there's other types of depression in addition to seasonal affective disorder. There's persistent depressive disorder, or chronic depression, and the mnemonic here is 2. That is, for at least 2 years, there's not been more than 2 months where you've been well. 2% of the U.S. population has it, and they don't have 5 vegetative signs. If they had 5 vegetative signs, it would be major depression. Adjustment disorder with depressed mood is where something bad happens and you feel bad after that for more than 30 days, up to 6 months. The treatment for that generally is psychotherapy, or benzodiazepines can be used. Let's move on briefly to bipolar disorder. Bipolar disorder is probably easiest thought of as being the opposite of major depression. That is, you have increased energy, decreased sleep, increased thought speed, all kinds of plans, all kinds of ideas, and you can become psychotic in mania because you get so revved up, so entranced with your own ideas. Bipolar 1 is classic manic depressive illness, about 1% of the population. Bipolar 2, typically there's little blips of mania with longer or more frequent depression. 2% to 3% of the U.S. population has bipolar 2. Symptoms usually begin in teens, usually first diagnosed in their 20s, and is chronically recurrent. Unfortunately, patients typically spend about half of their lives symptomatic. Depression's more common. Of the time they're symptomatic, twice as often they're depressed. What medications to use for mania? Lithium, anticonvulsants, and antipsychotics. Lithium is underused but can be difficult to use. It has a narrow dosage range and a lot of side effects: weight gain, skin, kidney problems, thyroid, parathyroid problems as well. The anticonvulsants, many of them can be used: valproic acid, carbamazepine, oxcarbazepine, topiramate, lamotrigine. Lamotrigine is especially helpful in depression in bipolar disorder. Remember that anticonvulsants are especially dangerous in pregnancy. 5 to 8 to 9% of pregnant women can develop neural tube deficits or spinal bifida if they are on those while they are pregnant. For bipolar depression, there are several FDA-approved drugs. The olanzapine fluoxetine combination, quetiapine, lorazepam, and cariprazine or Vraylar are all medications that are helpful. But remember, ECT is the most effective treatment for mania as well. So remember, with mania, as with all affective disorders, you have 2 jobs: to get somebody better and to keep somebody better. Very often in bipolar disorder, one pill is not going to do it. It is common to add on medications. If you can, you try to avoid the use of antidepressants, because antidepressants will raise your mood, but it can raise it further into mania. And about 20% of people on an antidepressant who have bipolar disorder can be switched into mania. And when that happens, they can have more frequent episodes. So beware of that. So I apologize, this is longer, But read more about affective disorders. No matter what branch of medicine you go into, you'll see these frequently in your practice.